Hi, everybody. My name is Stuart Schlossman, and I'm president and founder of MS Views and News. And tonight's program, well, we are a MS Views Now program. All right. This is a virtual series that we began at the beginning of this pandemic. And the idea of this series was to bring relative COVID information to you. When I say relative to the date that we're doing the program. So if you're watching this in 3 months from now, you're going to say, wow, this looks strange. I remember this happening a long time ago. And it was, all right, when you watch it in 3 months from now. So anyway, for tonight's program, I wanted to thank our supporters. We, as you can see on the screen, we have Biogen, we have Genentech, Bristol-Myers, Squibb, Sanofi Genzyme, and EMD Serono, and I want to give them a virtual thank you. Okay, great. All right, so for tonight's program, we have our presenter is Megan Weigel, and Megan is the founder of the First Coast Integrative Wellness Center in Jacksonville, Florida. I'm sure you might hear a little bit about that later on. I just wanted to thank you all for being here. What we're going to do tonight is a little bit different than our previous programs. Normally, I break up the program. The presenter will speak for about 10 or 15 minutes, and then I'll come on and do questions. But tonight, we're not going to do that. Tonight, we are going to take your questions, but we're going to let Megan speak for about 25 or 30 minutes. When she's finished, we're going to open it up to questions. So that way, there's no loss of, her direction on what she's doing or what she's speaking about. But before I let Megan speak, please know on the right side of your screen is a arrow. And if you click on that arrow, there's a place for you to type in your questions. So please go ahead and type in your questions as she's talking. If you have any questions to ask, just type them in there and we'll get to them after she's done presenting. And by the way, I'm going to mention your first name, okay? And so what I'm going to ask is that if you don't want your first name mentioned for whatever reason, I mean, if you have a common name like Cindy, I mean, there's a lot of Cindys it could be, all right? But if you have Aloysius, all right, I understand. Maybe you don't want that name mentioned, all right? But I will say your first name and with your question, and we'll go forward from there, all right? So let's give it to Megan. I mean, she's all happy to do and ready to speak with you all, and I'm going to get off here. You'll see me back in about 25 minutes, all right? Thank you.
Thanks,
Bye-bye.
Stuart. So we're going to talk about living well with MS during the COVID-19 pandemic. And our objectives tonight are to review facts about COVID-19 and its effects on the US, and then specifically talk about those statistics related to people living with MS like yourselves, discuss ways to protect yourself against COVID-19, and then discuss lifestyle measures that can improve your overall health and sense of well-being right now. So here's what we know about COVID-19. COVID-19, I'll take the next slide. Thanks. COVID-19 is the name of the illness that's caused by the virus SARS-CoV-2-19. It's a novel coronavirus. It was discovered with the first case in December of 2019 in Wuhan, China. Can be spread through droplets, usually by a cough or a sneeze, and the incubation period of being contagious is usually within 14 days of exposure. Most cases are mild, and I feel like it's super reassuring for people to hear that. We see bad things on the news, but most cases are mild. And the best analogy that I can give is that if you go to a restaurant and it's bad, you're going to tell everybody. If you go to a restaurant and it's good, you're not going to tell anybody. So we're going to hear much more about the severe cases. Symptoms are many. In fact, when you look on the internet for symptoms of COVID, it's anything from respiratory symptoms to GI symptoms. And I will say that for the most part, it is a respiratory illness, and the part of the illness that leads to moderate to severe disease and death is the respiratory inflammatory syndrome. But between 33 and 68% of people will lose their sense of taste and or smell when they're infected with the virus. And that is pathognomonic, really, for COVID. It can happen with other things, with other sinus and upper respiratory infection issues, but it's not common. And it's almost complete. Many treatments are being studied to manage more severe cases of the disease. There's been at least one variant described, and the first case in Georgia, I believe, was pronounced within the past couple of days. And it's caused a pandemic. It's caused a global pandemic. Next slide, please. So as of January 5th, when I made these slides, the US reported cases were 20,825,423, with 353,640 deaths. Global reported cases are over 85 million, almost 86 million, with close to 2 million deaths. And I was just listening to a podcast today from an epidemiologist at Johns Hopkins, actually. And basically, by the middle of the year, the United States was 300,000 over the usual death rate for all cause. And so that's how we know that this is more severe than things that are just related to the flu. And it doesn't mean that all of those deaths, obviously halfway through the year, are related to COVID, but they're related to complications of a pandemic. So there's not enough hospital beds for people who have regular illnesses, let alone just COVID at this point from an ICU standpoint. So the pandemic has a trickle-down effect. People aren't seeking care like they used to because they're afraid to go to the doctor. Next slide. So risk factors for COVID. One of the greatest risk factors is age. And so depending on the website that you look at, you might see 55, 65, 75. The fact of the matter is that 8 out of 10 COVID-related deaths have been reported in adults age 65 years and older. And with every decade that you're older, you have a greater risk of severe COVID and a greater risk of death. And there's actually a chart plotted out for that on the CDC website. Adults of any age with cancer, chronic kidney or lung disease, Down syndrome, heart conditions, an immunocompromised state from a solid organ transplant, obesity, severe obesity, pregnancy or sickle cell disease, smoking or type 2 diabetics are all at increased risk of severe illness. Next slide, please. So treatment is twofold. Prevention. First of all, we're still masking, we're still social distancing, we're still washing our hands often, we're still not going out in large gatherings, we're still covering our coughs and sneezes. In fact, it'll be interesting to see if we have a lower rate of flu this year because everyone's a little bit more hygienic than they were before. We're still disinfecting surfaces, we're still monitoring our health, like checking temperatures, when we go to school and the doctor's offices, and even within homes. I know families, larger families who live within a home where some children are in school or parents are working and people are moving about now more than they were, checking their temperatures daily. As far as treating the infection itself goes, remdesivir has been approved to treat COVID-19. Other treatments may be available in a clinical trial setting or through the FDA's Emergency Use Act, but remdesivir is the only one so far that has been FDA approved for moderate to severe COVID-related illness. We use a myriad of other treatments in the hospital to treat the symptoms. And it really just depends on the person's presentation and their past medical history, what might be tried. There are handfuls of trials going on with different types of medications to basically see if we can treat this well and cheaply with medications that we already have. Next slide, please. So what do we know about COVID-19 and people living with MS? Well, we know a little bit. There's a registry called COVID-MS. This registry is a voluntary registry, so it's not complete. All people with MS who have had COVID are not on this registry. This registry was developed for healthcare providers to self-report cases of COVID. So as of right now, there have been close to 1,800 cases of confirmed people with confirmed MS reported with COVID. 85% of those cases are laboratory positive, which means 15% are suspected or unknown. 62% have recovered, 27.3% are recovering, and 3.3% have died. So as you can see here, COVID, for the most part, is a mild illness. 14.5% of people in this registry were not on disease-modifying therapy. 81% of cases were in people with relapsing remitting MS. 77% of cases were in ambulatory folks. People always have questions about disease-modifying therapy. So of the reported cases, 34.6% of the people were on ocrelizumab, 15.2% of the people were on dimethyl fumarate or Tecfidera, and 13.1% of people were on natalizumab. I'm sorry, I have my pattern switched there. And again, these are of reported cases. This data doesn't necessarily mean that the people taking these medications, that if you're taking one of these medications, your risk for COVID is greater. This is just the data that we have here. What's important is, oh, go back one more time, Bill. Sorry. What's important is, and I missed a percentage. What's important here is to know that people just living with MS is not a risk for severe COVID. What is a risk for severe COVID in people living with MS is having a comorbidity. 46.2% of people had something other than MS or in addition to MS. 20% of those comorbidities are high blood pressure, 11% are morbid obesity, 8.4% are diabetes, and I just picked the top three. Interestingly, I think in the top three was other, and I'm not sure what other was defined as. So having a comorbidity does increase the risk of severe COVID, just like I mentioned on the previous slide. Okay, now I'm ready. So risk factors for more severe COVID cases in MS include progressive MS, people with MS over the age of 60, men with MS, Black people with MS, and possibly South Asian people living with MS, people with higher levels of disability, and that's because of the respiratory syndrome. It's proposed, it's theorized that people with higher levels of disability may have some issues with clearing secretions, or because they're sedentary, may be more prone to infection. And so that's where that comes from. And then also, as I mentioned before, people with MS and obesity, diabetes, or diseases of the heart and lungs, and the other things, the laundry list of things that I mentioned from the CDC website. It's also thought that people taking B-cell therapies like ocrelizumab, rituximab, and ofatumumab, so that would be Ocrevus or Kesimpta, and then Rituxan, may be at an increased risk of more severe COVID-19. Next slide. So here are our pandemic problems. I mean, I probably could have gone on forever, but as far as I see them as they relate to having multiple sclerosis and medicine, telemedicine is not going to go on forever. In fact, we've been told that we need to start seeing people live because of reimbursement. And in order to be able to continue to practice, we have to be reimbursed by insurance companies, so doors have to stay open. I have a feeling that with the new rise in cases, that insurance companies will extend their length of time that they will continue to pay for telemedicine, but it's not going to go on forever. I like it. I think people like it. However, you can't hide behind your phone or your computer forever. Your healthcare provider needs to see you. I really worry about people who, every time I talk to them on the screen like this, they say they're fine, they're doing great, and I ask them to position their phone or their iPad in a certain way so that I can examine them, and they say, oh, no, I can't do that. I don't have anybody here to help me. And almost a year has gone by and I haven't seen them move because they can't prop their phone up, and I can't make them do it. I'm not there. Also, people are afraid to access medical care because they're afraid of COVID. They're afraid to access rehabilitative care because they're afraid of COVID. So What worries us as healthcare providers and should worry you as people living with MS is just a gradual deconditioning because you don't have access to the things that you used to do to try to move your body, including regular live exercise, although there are a multitude of opportunities to stay active virtually. I need to go back. I'm sorry. We have to treat multiple sclerosis. And so when we think of disease-modifying therapy as a pandemic problem, what do we do? The decision to start, stop, or change a disease-modifying therapy is very individualized. And as you saw, COVID is for the most part a mild disease in most people, and MS is can be equally as devastating. So we have to consider that. And then there are the problems of isolation, mental health issues, financial issues from employment being odd or off or not even present right now. Okay, now you can go on. So how do you protect yourself? How do you protect other people? Couple of things. We talked about some of these already under prevention, but in general, you want to keep your bubble small, your pod, whatever you want to call it. My bubble is very small. It's my husband, my son, and myself. My son does go to school, and as I thought would happen, he's already had one case in a upper school classroom, and they're now going to homeschool for 2 weeks. I predicted it would happen after the holidays, just because of travel and people, guess what, making their bubbles bigger, making their pods bigger. Wear a mask when you are outside of your home and indoors. Wash your hands or use a hand sanitizer that has at least 60% alcohol in it. Follows the CDC guidelines for exposure and for if you do contract the virus. And if you haven't looked at them for 6 months, they've changed just based on what we've seen in the community. So if you are exposed, the CDC website, when you go to cdc.gov, COVID is right there in front of you. And if you click on that, you can find all of the information that you need. Also take care of your general health. So if you have other medical conditions, it's just super important that you're seeing those specialists as well and that you're taking those medications and that you're doing the things to keep those medical conditions in check. And then consider the vaccine. So we'll talk about that. It might even be on the next slide. Oh, look at that. COVID-19 vaccines. Oh, it was just... it was such a topic of debate until we had more to debate in the past 6 weeks. There are 2 FDA-approved vaccines here in our country. There's the Pfizer vaccine and the Moderna vaccine. They are both messenger RNA vaccines. They have both been studied in over 30,000 people in their clinical trials. The Pfizer vaccine studied folks up to 89 years of age. The Moderna vaccine doesn't state how high their age went, but there were over 7,000 people over 65 years in that vaccine trial. Pfizer vaccine is 2 doses given 3 weeks apart. Moderna is 2 doses given 4 weeks apart. Today, I just read an article about splitting up doses so that more people can get a little bit. I haven't looked into that at all, so I will tell you that right now. If there's a question about it, I have no idea what the answer is, but my just basic science mind tells me that doesn't sound kosher. Pfizer vaccine has 95% efficacy. Moderna has 94.1% efficacy. The Pfizer vaccine had 6 cases of anaphylaxis, 4 cases of Bell's palsy, which is not outside the normal incidence rate when you look at a population of people. The Moderna vaccine had 4 cases of Bell's palsy as well, 3 in the vaccinated group, 1 in the placebo group. The Pfizer vaccine has limited data in pregnancy, no data in autoimmune disease. The Moderna vaccine was studied in pregnant rats, and there were no safety concerns in rats that were pregnant, but there's no data in autoimmune disease. The Pfizer vaccine needs to be kept refrigerated at an incredibly low level. It's difficult to store. Moderna is less difficult. So let's talk about how these work. So many people have been trying to come up with a good analogy about how they work, and I in my head, like I know how it happens, but I have a hard time explaining it. So on the left here, we have a pictorial from the NIH, and basically you get an injection. The messenger RNA vaccine has a code for the spike protein of the coronavirus. It's injected into your muscle, and then the vaccine triggers production of the spike protein and antibodies specific to it, so that when your body comes in contact with it again, it can recognize it. And then the RNA is destroyed by your body. So you can think of mRNA vaccines as temporary messages that get torn up after your immune system builds its response to that message. It does not continue to live in your body. This specific type of mRNA vaccine does not replicate in your cells. There are other types that do. These two vaccines do not. Immune modulating therapies may affect your body's ability to mount a full response to the vaccine. So timing of the vaccine is going to be an issue in MS depending on the disease-modifying therapy that you take. Next slide. So here's some thoughts about the decision to vaccinate. First of all, I think it's great to know, reassuring to know that the National MS Society has convened a team of experts to provide guidance to people living with MS around the safety, efficacy, and timing of the COVID-19 vaccines. As many of you are aware, there is a tendency to not recommend live vaccines to people living with MS unless absolutely necessary. This is not a live vaccine. At least these two approved vaccines are not live vaccines. So more to come from that committee. It's very well stocked with MS experts, physicians, PhD scientists, and nurse practitioners. There might be a PA on the committee as well. But this chart on the right-hand side was reassuring to me because it was posted on a holistic physician's website, and I get many questions about vaccination because I am an integrative medicine practitioner. So people automatically assume that I'm going to be an anti-vaccinator, and I'm not. I am pro-vaccination. So Dr. Christensen is a naturopathic physician. He's been featured on Dr. Oz many times. He has a very good reputation. And because he's a naturopath, people would expect him to not recommend the vaccine, and that's not what he's doing. He's actually recommending the vaccine. So in this chart, you can see that you have two choices. You have door number 1 and door number 2. And door number 1 is the COVID-19 infection. Door number 2 is the COVID-19 vaccine. And these, what you'll see here, these numbers have actually been calculated to be rates. So they are side effects per 10,000 people. So COVID-19 infections, of course, we know that that's basically what you have when you get infected with COVID-19. There have been cases of COVID-19 infection per 10,000 people, 5 to 10 in the vaccine clinical trials, and those are well documented in the clinical trials. They're in people who were exposed to the virus before they had the vaccine. So these cases weren't thought to be caused by the vaccine. But you can see in door number 1 that actually getting the COVID-19 infection puts you at a much higher risk for serious adverse events. Whereas getting the COVID-19 vaccine, the only things that come close to COVID-19 infection are fatigue, and muscle aches and joint pain and headache, because truly there are side effects from this vaccine. Nobody's denying that. There are side effects from the vaccine, purportedly side effects from the vaccine like fatigue, aches and pains, fever, headache, are more common after the booster shot is given. But as you can see here, from what we know of our data now, and I will agree with all of you that the trials are short, that these vaccines were rushed, that we don't have the usual amount of time to document adverse events. whether they be mild, moderate, or serious, as we do with drugs that are studied for longer. You can see here that COVID causes over 200 ICU admissions per 10,000 people, and there's been one with the COVID-19 vaccine. COVID causes between 250 and 500 strokes per 10,000 people. There's been none with the COVID-19 vaccine. COVID causes long-term symptoms in 6,000 out of 10,000 people. There's been none of that with the COVID-19 vaccine, so no long-term side effects that we know of. COVID causes 180 deaths per 10,000 people. There have been no deaths related to the COVID-19 vaccine. And additional COVID-19 infections from transmission to others is actually greater. So if you're a person with COVID, your tendency is to infect at least 2 to 3 people, whereas if you have the vaccine, you're not infectious. So you can also see on the far right column that they also documented things from a saline placebo. It's a placebo effect. Interestingly, a lot of people who had this placebo had side effects as well. Next slide. So here's the importance of wellness. We have little control over so many things these days, but we do have control over what we put into our head, the thoughts we put into our head, the foods we put into our mouth, and the things that we let into our heart, and the ways we move our bodies. So these are quick run through of my 8 pillars of wellness: MS management, nutrition, movement, stress management, sleep, social interaction, as we can right now, risk factor modification, and learning new things. Next slide. MS management, it's important for you to keep your regular MS checkups right now, whether they be virtual or in person. If you're uncomfortable going to an office in person, call and ask what their policies are. Maybe you can be seen early in the day or later in the day. Have your MRIs had any changes? Do you have new symptoms, or have you noticed disability changes? Is your disease modifying therapy working for you as a person and for your MS? Are your symptom management medications working? Do you need a rehab tune-up? Do you need specialty referrals? Next slide. Nutrition. I'm not going to go into great detail about this because there are other webinars that go into great detail about this. But my main rules for people are eat food, not too much, mostly plants, and the right diet for you is the one that you will follow. I also hate the word diet. I think that nutrition or way of eating just sounds a lot better and more fun than diet. Next slide. Movement. What do you enjoy right now, and what's possible for you right now, and what's safe for you right now? So your goal is 150 minutes per week. That's about 21 minutes per day. You want to move at your best time of day. No matter what the temperature is where you live, you want to use cooling equipment and drink cool fluids, because your core body temperature can exacerbate your MS symptoms, make you feel more fatigued, make your legs weaker, make you feel more spastic, whatever it is that happens to you if you're sensitive to increase in temperature. You can split up your exercise if you need to. The cardiovascular benefits are the same. So if you really tucker out at 10 minutes, then do 10 minutes in the morning, 10 minutes in the evening. And involve your family and friends. In our neighborhood right now, families walk around the neighborhood at night. We say hi to one another. We're outside. It feels good. And it's also nice to have that connection with people, even though it's not like it used to be. Next slide. Stress management. Oh boy. I could talk about this for hours and hours and hours. Depression and anxiety are super common in MS. The rates of depression and anxiety are high right now because of the pandemic, because of the elections, because of vaccines, because of employment, because. If you are feeling symptoms of depression or anxiety that are difficult for you to control, that are affecting your life or your relationships, please don't just say, oh, it's because of COVID. Please ask for help at your MS provider's office, at your primary care doctor's office. Alcohol is a problem right now for many people. I can't tell you how many people I see every day who are like, well, I've really been drinking a lot more during the pandemic. And when I tease things out, that translates to drinking during the day, almost every day. It's a big deal. So if you're having these issues, this pandemic isn't going away. We probably have another year of this wacky, wild stuff, figuring out how we can move about safely. So it's really important to address your mental health. Is it disrupting your life, your stress? Do you need meditation or do you need medication? Meditation, mindfulness, breathing, moving your body with exercise, getting fresh air outside, getting sunlight, all of these things can improve your mental health. Decreasing caffeine can improve anxiety. Decreasing alcohol use can improve depression and anxiety. It may feel better when you're under the influence, but withdrawing off of it actually causes increases in anxiety and depression. Reducing sugars and processed foods in your diet can also make a big difference in your mood because of the gut-brain connection. Just eating fresher, healthier foods, or putting better fuel into your car. Increase your omega-3 fatty acids with food, increase plant foods in your diet, and then simply learn to say no. From what I've heard from folks right now, people assume that since folks are home, that they have more time. You may nod your head and say, yeah, my employer now asks me to be on meetings at 7 at night. There is no regular start and stop time like there used to be. You're a teacher, you're a parent, you're a worker, you're a caregiver, you're a support partner, you're a person living with MS, you're all of these things. And you can't escape your home. You can't do the things that you used to do. So learn to say no, really prioritize what's important to you right now, and learn to create boundaries. And if you need help with that, consider seeing a counselor, even if it's virtually. Next slide. Sleep. Sleep is affected by all of these things. My hints for sleep right now: turn off the news right now. Everybody turn off the news. If you need to watch the news, which I think it's important to do right now, limit it to times a day that it's not going to affect your sleep, when you can handle a little ramp up in anxiety. Avoid using electronics for at least an hour before bed. And if you do read on a handheld device like a Kindle or a Fire Stick or whatever they're called, an iPad, use a blue light filter. You can actually buy a screen on Amazon, just like a stick-on cover for the handheld device, or blue light blocking glasses, because the light from the computer affects your pineal gland, which is the gland that releases melatonin and the hormones that help us with our sleep-wake cycle. And also create a calming ritual before bed. Maybe you write in a gratitude journal, or you do some gentle stretching, or you put an essential oil that relaxes you in a diffuser, or you drink some decaf herbal tea if it's not going to get you up to go to the bathroom all night long. Those are just some things that can be nice to calm you down. In memory studies, social interaction has been shown to be associated with the least cognitive decline. So we can't be socially interactive like we used to be right now, but you can make plans to see family. Even just having something to look forward to, even if there's a caveat of we may have to cancel this, or that sort of thing, or we may have to postpone it instead of using the word cancel. But make plans to see family and your closest friends. Do it safely. Consider virtual support. Attend programs like this. Meet outside in small groups. The driveway meetups are very common over the Christmas holidays. My husband and son and I visited with my husband's parents in their backyard. We each brought our own picnic, so we didn't have to share food. We had a big fire going. It was a beautiful day, and we felt very comfortable. And we were just so glad to be together, even though it looked different. Next slide. Risk factor modification. So all of the previous things I just told you about help modify risk factors for vascular disease. Take your medication as directed. Consider food to also be like medicine, and see your primary care provider regularly, as well as keep appointments with your other specialists. We want to decrease your risk for vascular disease, because having just one vascular comorbidity like hypertension, diabetes, high blood pressure, heart disease, peripheral vascular disease can increase your EDSS to 6 by 6 years, which means you're 6 years faster to using a cane if you have one of those. Next slide. Learn new things. So everything is available virtually, you guys. I mean, you could literally just get so excited with all the things that you can learn virtually. And many of those platforms for learning are cheaper, and they take less time than they used to. So anything in person takes longer because, well, we're social creatures, right? So we chit chat, we ask more questions. So a class that was live in 5 days might now be virtual in only 3 days, and it also might be cheaper. Take advantage of it. Learn a language, learn to play a musical instrument, consider music therapy, actually. There is a lot of music therapy happening that's virtual. Take up a new form of exercise or moving your body, like yoga or Tai Chi or Qigong or dance. Play like a child. And by that, I mean, for those of you who have kids or grandkids, watch them. Watch how many things they do with their hands that help with their fine motor control. They can help you too. Putting together Legos, beading, painting, doing crafts. I didn't mention art. Just art therapy, crafting can be helpful for you. Gardening can be helpful as well. Read. And of course, you can use computer-based cognitive games if that's your thing too, but just do something different with your mind and your body. Next slide. So I heard a quote by Norman Vincent Peale the other day that just really inspired me. And so I went and looked up other things that he said, and I found this and I love it. Our happiness depends on the habit of mind we cultivate. So practice happy thinking every day. Cultivate the merry heart, develop the happiness habit, and life will become a continual feast. So in spite of what is in front of us that we can't control, learn to make effort to control what's inside of you. And that is it for my slides, and I'll go ahead and take questions.
Hey, I'm back. How about that? All right, so we do have a lot of questions. I'm going to take this off, though. We do have, before I get into the questions, Megan, I just got to let everybody know. First off, I want to thank everybody. We got 97 people online tonight. That is awesome. Really, really awesome. This is the first event of 2021. Yay, we got out of 2020, right? But I do want to let everybody know that this is our first event this month of 7 virtual programs. We upped our number from last year where we were doing 5 or 6, and now we're going to be doing 7. And beginning in February, all the way through to August, we're going to do a minimum of 8 programs per month. And some of the months we're going to have 9 or 10 programs going. When, I have no idea, because it's just a lot of driving back and forth to where I live and where I am right now, okay? Yeah, you can't take plane anymore, right? So anyway, I did want to say that, and I did want to say about the programs that are happening. Also, there are people asking questions, how they're going to watch this afterwards. Well, because we're ahead of schedule right now, and we are all caught up, I should say, this program will be on our YouTube channel by Saturday midday, okay? It'll definitely be on there, as long as, I shouldn't say definitely. God knows what might happen, right? But it should be on our YouTube channel. And if you don't know how to access our YouTube channel, please visit our website or our blog or our email newsletter, or you could just type in YouTube and go to YouTube and then just type in MS Views and News, and you will find our YouTube channel, okay? So that's all I'm going to say for right now. We do have a lot of questions. And Megan, I want to let you know about the splitting doses that different doctors did come out the other day and did say they're not going to do that.
Oh, good.
They're not going to do that at all. They only
Sounded
found
like a bad idea.
they only found the value of 30%, as a max of how of good things from one dosage. So they said no, they can't do that. And
Good.
my concern going forward is always, for all those people that did get a dosage or will get a dosage, what happens if the supply runs out?
Oh, and they don't get their booster?
Right. Then
Yeah.
what? Do might you have an answer for that? I mean, that's a
I have
question
no
that
answer
has
for
come up a lot.
that.
Okay. All right. No problem on that one. We'll leave that one alone. I got to get Dr. Fauci for that one. All right. All right. So let me start with, because almost everything is COVID questions. Let me ask, please, a few of the questions first that are not COVID. All right.
Okay.
And that, like, the first person wants to know, does learning a new language help with overall brain health?
Yeah,
I mean,
so
I can understand the value for that. Yeah.
learning new things is thought to help with brain health. Yeah. And a
Okay.
new language is part of that.
Okay, great. And what about even learning yoga?
So yoga is not only a form of exercise, it's also a mindfulness therapy. So it affects your brain in different ways. As far as yoga and MS goes, it can help improve spasticity, balance, pain, fatigue, mood, bladder function. What did I miss? Anxiety, sense of community. But as a mindfulness therapy, yoga has definitely been associated with decreased pain and anxiety. It's exercise, it's good for your brain. So yeah, my answer to that is yeah.
Okay, great. Thank you for that. And by the way, I forgot to thank you for your presentation. So, yay, Megan!
Thank you.
Way to go. All right, thank you. Katrina writes, when speaking about other medical conditions such as high blood pressure, diabetes, and etc., being a factor in the way things can progress, is that whether it's treated or not?
Yes.
That's the answer?
Yes. It's whether or not it's treated, you still have the condition. If you have the condition and it's treated and let's just say your numbers, whether it be your blood pressure or your hemoglobin A1C, are under control, so they're back in the normal range, then you are less likely to progress faster.
Okay, great. Thank you for that.
Yeah.
And Kim wants to know, I don't know where her question begins, but she says, of the 14% that were not on DMT, do we have the number or percent of death? I guess that's a COVID question, so I got to hold off on that. Sorry about that.
Okay, well, since you can keep talking and I'll look it up while you're talking.
Okay, we can do that. All right.
Yep.
How does education and learning new things overall help a person?
Well, I mean, it helps improve, learning new things creates new pathways in the brain, basically. So we think that, and this data is specifically related actually to Alzheimer's disease. So I'm extrapolating brain health from dementia to brain health with MS. The mechanisms of brain plasticity are different in those different diseases. But learning new things activates areas of the brain that you haven't used before, or activate areas of the brain that have been dormant for a while, or perhaps activate areas of the brain that are going to take over for other areas of the brain in the case of MS. So that's how learning new things helps with brain health.
Okay, great. Thank you for that. What can you tell us about people over 60 being on a disease-modifying therapy? This is sent by Michael.
As a group, I can tell you, I mean, nothing. I can tell you that the decision to continue or discontinue disease-modifying therapy, because I'm sure that's where that question is going, is a very individual. It's a very individualized decision. People have biological ages, and so that means a 60-year-old who's super healthy, who may have a biological age closer to 45 versus a 60-year-old who's an obese smoking diabetic who may have a biological age that's closer to 80. And that has a determinant on MS because of immunosenescence, or the thought that our immune system, our ability to be inflammatory is lesser when we're older. But there's also this smoldering inflammation that can happen. So it's a very individualized decision. DISCO MS, which is the study that's looking at discontinuation of disease-modifying therapy in people over 55. Actually, I think results should be published this year for that. So we'll know more. But even still, even with results of one clinical trial, I would still consider the decision to stay on or to stop to be very individualized. The course of the person's of MS, the disability that they have now, what other medical conditions they have, and so on.
Okay, thank you for that. And then there was a question on, is there any way that, Patty's writing, can we space out MRI from yearly to something else?
It depends on your MS. So if people have a very quiet MS, no changes for years on their MRI, no changes in symptoms, no changes in physical or cognitive disability, no relapses, then you can have a conversation with your doctor about spacing out MRI. I think one of the things that's more common now is maybe not using contrast every year in people who have stable disease. But yes, it's certainly worth a conversation, but it has to be really, really stable MS, because we know that overall lesion burden, overall level of brain atrophy, silent things accumulating over the years do result in physical and cognitive disability. So we are interested in those silent lesions.
Great, thank you. A person named David wants us to pull up a slide that you did on other factors of MS. Do you have that? Do you know what we're talking about here?
Men with MS, Black people with MS tend to have more severe disease. And so it's basically separating out the category of people with higher levels of disability. Men with MS, Black people with MS tend to have higher levels of disability, more severe disease.
Great, thank you. Thank you for bringing that back up. So, all right, let's go on to some other questions. Back to Michael. Michael wants to know, we're now getting into the COVID questions, all right? Michael wants to know, are there any concerns for people over 60 that are not on a DMT with COVID? Are there more concerns for those people?
No, only if they're in one of those categories, like progressive MS, men with MS, living with more severe disability. And just to answer the question about the disease-modifying therapy, and actually 2 days have gone by, and now 19% of people are not on disease-modifying therapy in that registry. So more people have reported, but they don't break down severity of COVID per disease-modifying therapy or per on one or not on one.
Right. So I think Megan is referring to the CoVMS website.
Yes.
Is that what you're referring to?
Yes.
All right. So for anybody that wants,
CoVMS.org.
Sure. So I was going to say, if you can't remember that, though, you could go to the MS Views and News website, and in the top center of that page is a banner that says CoVMS. You could click on that and get right into the references that Megan is referring to right now. Okay. Next, we do have another question that was not COVID related. I do want to say this again, and it is, what is a silent lesion?
A silent lesion is a brain lesion that doesn't cause a relapse. So it's something that shows up in your brain that is evidence of MS activity, either a scar, a plaque, or an enhancing lesion, but it doesn't cause you to have a relapse. So it doesn't show up as a new symptom.
Okay, thank you for that. And I'm going to mess up this name, but it's Tehimina. I probably messed it up. But anyway, he or she is saying, hi, thanks for this webinar. I've been diagnosed with MS 7 years ago, and I've had an MRI with contrast. Is that normal? Oh, I've never had an MRI with contrast. Is that normal? When is it required to have contrast?
Um, I mean, most people have MRIs with contrast yearly, certainly at the time of diagnosis, and sometimes during a relapse if a person is re-imaged. Reasons to not have contrast would be refusal, a patient refuses it. Also kidney disease or poor kidney function. So I'm not sure why she hasn't had contrast.
Okay, thank you for that. By the way, for the person who wrote that my tie is loud, I'm sorry, but I had to do something for this. All
I
right.
like your tie. Like the
Thank you,
color.
Megan. Thank you very much. All right, great. All right, next. We're going to only do COVID now because our time is running low and we want to get this going. We have about 20 more minutes to do this. Okay, Megan, you good with
Okay.
that? Okay, great. First one, interesting, of course. How can MS patients get priority status for the vaccine?
I have no idea. It's county dependent, which is then state dependent, and each county and each state have set different parameters. MS is not going to put you into a category of importance. If you are over 65 or 75, depending on the state of which you live, and if you have one of the other diseases, because MS doesn't increase your risk for severe COVID. So if you have one of the other diseases, then one of the other conditions that increases your risk for severe COVID, then that could help you prioritize. And I think that if you're having a hard time, you just get a letter from your doctor to take to the health department.
Great, thank you for that. All right,
Mm-hmm.
so again, I think what people don't understand is that they having MS does not make them more suppressed. Your immune system's
Yeah,
not suppressed.
let's talk about that for a minute.
Yeah, let's
So
talk about that.
I think that's great. Thanks for restructuring that. So having MS does not increase your risk for severe COVID. Having one of the other medical conditions that's listed on the slide that I mentioned does. So if you have MS and one of those medical conditions, then your risk for more severe COVID is increased. There is another list on the CDC website that that is like a contingency list. Like, we're not sure, but maybe, and you may even have a condition on that list. One of the confusing points, again, is disease modifying therapy. Well, so if I'm on X, Y, or Z disease modifying therapy, then I'm immunosuppressed. Well, the category of immunosuppression for more severe COVID is related to solid organ transplant, not being on a disease modifying therapy. Actually, interferons used for MS may be potential treatments for COVID. There has not been an increase, or we have not seen that being on Tecfidera, fingolimod, Aubagio increases your risk for COVID. In our country, in Italy, in the Middle East, papers have been published that suggest that B-cell therapies, as I mentioned before, could potentially increase your risk for more severe COVID. So, that as far as vaccination goes, I think that, if you can't, I wish that I could say that I knew for sure how to help everyone get vaccinated, but the fact is there's a priority list, and many of us are going to have to wait out that priority list. My husband's not going to be able to get vaccinated because I'm a first responder. So, and that's why we stress the importance of still wearing masks, still socially distancing. All of these things that we aren't, we're not loving it, right? But we've got to do it.
So you just hit on something though that you said about masks, and I'm going to bring this up because it's important for people to know, and that is that even after you're vaccinated, you still have to wear a mask. Bottom line is they don't even know if what you just got vaccinated with is working for you. So it is best that you still keep on wearing it, correct?
Yeah, we don't, the vaccine, we don't know how long the antibodies last from the vaccine. We don't know how long antibodies last from the virus. Neither one of them have been around long enough. And as far as herd immunity goes, I was listening to that same podcast from John Hopkins today. It's 2 hours long. I got 20 minutes in, but they were talking about herd immunity, and herd immunity based on, there's a number called R0 or R0 that's used in epidemiology that is basically the percentage of people that need to be infected with something to reach herd immunity. And it has to do with how many people one person is capable of infecting, all of these statistics. And herd immunity, would you mind if I ran and got my phone? Because I took a screenshot and I think it's important.
So while you do that, you can run in for that, and I'm just going to, I had something to say. Oh yeah, you could do that. I have something to say to a lot of people asking me the same question. So there's a lot of you all, okay, while Megan's gone, there's a lot of you all that are asking if we can replay a screen. No, we can't at this point in time. We are running low on time for Megan to be on here, okay? But again, as I said, we will have this published on our YouTube channel by Saturday afternoon, okay, is what I've been told by my video producer, all right? So we will get this up. You will be able to watch it again before the weekend is over with, and that's the best I could say about this right now, all right?
So this herd immunity for the seasonal flu is for the seasonal flu takes critical proportion of 23% of people, 23% of a population to be infected with the flu to reach herd immunity, because typically one person infects 14. With the coronavirus, it's 60% of the population that has to be infected to reach herd immunity. So we're not near there yet.
Right. Yeah, actually. And
that's why we have to continue to follow these precautions.
Where did you see that about the 60%?
It is in this Johns Hopkins lecture.
Okay, great. I just wanted to have as a reference point.
Yeah.
Because we are asked that a tremendous amount of the time. All right, let's get on to some other questions here, all right?
Okay.
Too many questions, all right? As a person and others have written, as an Ocrevus patient, how effective is the vaccine, and when to use the vaccine in relation to when they will get their next infusion?
I'm going to bring my special guest in.
That's good. Hello, Dane.
So, B-cell therapies like Ocrevus affect your body's ability to mount a response to the vaccine. Other vaccines are recommended to be given at least 2 weeks before your next infusion of Ocrevus specifically, because it's given 6 months apart. It's going to be more of a problem with Kesimpta, which is given monthly. We don't have any data to tell us whether or not a person on Ocrevus who gets the COVID-19 vaccine will mount any, if at all, meaningful response. We don't know.
Okay.
Yeah.
All right. Thank you. How best to time vaccinations if on B-cell infusions?
Same thing. So you want to give a vaccination about at least 2 weeks before your infusion, 2 to 4 weeks before your next infusion.
Okay, thank you. All right, next, let's switch off to the top again. Let me go to another page. Here's a great question. If you have COVID-19, are there antibodies already, and therefore you have antibodies already in your blood? Is there any harm in getting the vaccine?
There shouldn't be harm in getting the vaccine, no. And I'll just give myself as a case example. I had COVID at the end of October. I was exposed October 21st. I antibody tested on December 23rd, so 8 weeks later, and I don't have antibodies. So I'm going to test again in 4 weeks, mainly because I'm curious. It can take 3 months to mount an antibody response. They think that the antibody response lasts longer than they initially thought, but then healthy people might not ever test positive for antibodies with healthy people with mild illness. So we just don't know enough. Even if I test positive, this is my personal decision, even if I test positive for antibodies, I will still line up to get the vaccine.
Great, thank you. Next one, and this goes both ways. People are asking if they have MS and have not had the COVID virus, should they get the vaccination? I mean,
I recommend the vaccination.
Exactly.
Yeah.
So it's not just Megan, everybody. Every MS specialist that we've had on our channel over the last several months have all said, get the vaccine, right? Make sure you guys get the vaccine. And that's where we're going to go forward from there. All right, Megan's now working in the darkness, they say.
No, I'm sorry. He wants me to turn the fan off. It's cold outside.
Okay, gotcha. All right, next one. Between infusions, is there a time to wait? Should somebody get, all right, you said that there's a certain amount of weeks to wait before or after an infusion and doing like a B-cell therapy or Ocrevus. What about if they're then due for their second vaccine?
So that's the problem. The problem is we can't, based on the way that COVID is timed, we can't, we can't, you would just have to then get a booster, either when the boosters due and hope, or, wait until that time window again within that 2 to 4 weeks before your infusion, knowing that you're not going to mount the full response anyway.
Great, thank you. Hey, by the way, for all you people out there that have little kids, I bet you could feel for Megan right now, right? Ooh. Okay, great. All right, here comes a new one. Person asks that I do not give a name, that she is a healthcare worker with MS and has gotten my first dose of the Pfizer vaccine. No side effects other than a mildly sore arm. Do you know of anyone who is researching the outcomes of the vaccination?
I mean, I don't know of anyone personally, but as far as MS goes, people with MS getting vaccinated and outcomes, I'm sure the National MS Society, that committee that they formed, will be looking at that. I know that, the big, large bodies of, hey, buddy, careful, hey. Okay, oh, that's good. The governing, bodies that have, I'm sorry, Stuart, that have to do with, NIH, FDA, and Pfizer and Moderna, they all have to come up with data for, oh, Dane, you turned the lights on. They all have to have data, post-marketing data. They have to follow the people in the clinical trials that were vaccinated.
Sure.
And then I'm sure that there are phase 4 studies going on as well. I just don't know where they're coming from.
Okay, so that everybody knows, I believe next week, the National MS Society is coming out with a paper that talks about a lot of what Megan is speaking about right now. I'm not allowed to say more than that. I do know more than that at this point in time, but I'm not allowed to say more. This is all kept in the dark for right now. And when they are ready, they will make sure that all the T's are crossed and the I's are dotted, all right, and that the correct information is put out there. But that should be coming out next week, okay? All right, next, what about Kay writes, what about T cell and, sorry, I just lost this. I got a glitch in my screen here. What about T and B cells, CD4, CD8 counts under 100 and an IV therapy for SPMS? I guess that this is a little bit different than where we are right now, but I said it so you could answer it.
I honestly don't know.
Okay.
Yeah,
All right,
I don't, an IV therapy for SPMS. I mean, the only IV therapy that I can think of that would be used in secondary progressive MS with relapses would be natalizumab and Ocrevus. And I truly do not know about vaccinating with CD4, CD8 counts below 100. I just don't know the answer to that.
great. Kay, the question you have about when should the vaccination and when will a patient mount a COVID antibody? I think Megan answered earlier, but I'll let her say it again right now.
Well, with vaccination and the COVID antibody,
Yes.
well, from the vaccination trials, that's how we know that we need to get a booster to mount an appropriate antibody response. In those clinical trials, 95% for the Pfizer, 94.1% for the Moderna vaccine mounted an antibody response. As far as how long that lasts, I haven't found that data yet.
Okay. All right. Thank you for that. And another good one that we had here is I've heard the coronavirus vaccine only has approximately 30% efficacy for patients with, and again, this is a little bit different than what was said, with suppressed immune systems, such as myself. Again, everybody, please remember, you having multiple sclerosis, you do not have a suppressed immune system. Megan did say that, as well as every doctor that we've had on here. But so again, though, this person is also asking about the efficacy with patients that are using Ocrevus. Do you have any answers on that?
Yeah, so your immune system, again, is like you said, is not suppressed from MS. Your immune system may be suppressed from medication that you're taking. And we have theories right now. We don't have trials of people on Ocrevus who've received the vaccine. So there is not a number available. We can only theorize that based on what we know from Ocrevus and other vaccines that the antibody response mounted would be muted or less.
Great, thank you. So here comes a different question, and this is Maureen is writing. If a person is overweight with type 2 diabetes, well controlled, and you have MS, and if you try to lose weight down to your ideal weight, will this lessen your risk for COVID or really not make any difference?
Yeah, I think that if you have any of those risk factors for more severe COVID and you control those risk factors, then your risk for more severe COVID is less.
Okay, great. Thank you. Now let's get into something also different. Since this is new in the news, what can you tell us about the more contagious strains that they're hearing about?
So I actually took screenshots of that today too. So the new variant has been referred to as B117 or VUI 22012-01. It contains at least 17 mutations from the original COVID-19 virus. Some of them are to the spike protein. It's thought to be 60 to 70% more contagious than the prior strains that we know about. Some theories suggest increased viral shedding and increased transmission among younger people specifically, but it does not appear to be associated with increased severity or mortality. As far as number of cases or the map of the US where cases have been reported, I think I heard Colorado, Texas, and as I mentioned, Georgia. I have not spent time researching, those numbers.
Okay, thank you. All right. Hard to imagine, but we're getting down to our final questions, all right?
That's good, because my son just peed in the pants.
Oh, boy. Really nice. Thank you for that.
You're welcome.
We all wanted to know that
on
one,
TV.
all right? Next one is, what do we have here? My Ocrevus infusion is scheduled for February 1st. Should I postpone? everybody's going, oh, is everybody only on Ocrevus these days? I mean, it's incredible. So I'm 63 years old with a comorbid condition. Since I'm not over 65, I'm told I have to wait before I'm eligible for the vaccine. She must be living in Florida. Yeah. So I don't know what the question is here, though. Should I postpone in the hopes of getting so she was supposed to have her infusion on February 1st and wants to know if she should postpone the infusion in hope of getting the vaccine.
Well, you're in the window to get the vaccine, so I would make an appointment with your neurologist to talk about that.
Right. Michael wants you to know, go Megan, love the new norm.
Thank you.
Okay. All right. Maybe he's referring to everything going on around you, right? All right. Yeah. Another question off from COVID is, has any research been done with people with MS in mind? Maybe that is about COVID related.
Not right now.
COVID related. Has any research been done with MS people on their mind?
Not right now.
Yeah, that's why the COVID MS registry was started.
Let me do it.
So that we can follow people living with MS and their COVID experience, and see what, if anything really meaningful comes up with disease modifying therapies, and making recommendations about those sorts of things. And I'm sure someone will be following people with MS who are vaccinated and those sorts of things. That's great, buddy. I'm not surprised. We're outside.
All right. So now a couple of other people have written about 2 other different medications. Bottom line is, Megan, whether you're on medication or not, should they be doing a vaccine?
I absolutely think so, unless there's a contraindication to receiving a vaccine. And you'd know if you had one, if you'd ever tried to be vaccinated.
And
hey, buddy, get down.
Other than Ocrevus, is there a window that should be followed for having a treatment such as Tysabri before or after getting vaccinated?
With Tysabri, there's not really a window. It would be Ocrevus, rituximab, and Kesimpta where there would be a window. And I'm not sure about Kesimpta because it's given every month. I'm not sure what that would look like. With the other disease-modifying therapies like fingolimod and Aubagio and Tecfidera, they have only, at this point in their lives, looked at mounting responses to like the flu vaccine or other vaccines that are common. And in general, we're recommending, we recommend the people with MS get the flu shot, and there isn't any special timing that needs to happen with those oral or our older injectable therapies.
Okay, 2 more things, and then I'm going to let you go and take care of your little guy that got a lot going on. All right.
Yeah.
What about IVIG? What about IVIG for what you're talking about?
What about it?
So
IVIG for MS?
Yeah. Should there be a window when using it or not in relation to a vaccine?
I can't do that right now, buddy. Stuart, I honestly don't know the answer to that. I haven't looked into that enough. I'm sorry.
Okay, no problem. All
that
right.
Might be a question for her treating.
Last thing I want to say before I let you go, I need to let everybody know that this coming Saturday morning, we're doing an event. I'm doing an event with Dr. Aaron Boster. We're doing a live telehealth
I
call.
guarantee you Aaron knows the answers to all the questions.
Well, he does some. I know the answers to a lot of these, but I'm not allowed to say them. All right. And, just listening with all the doctors and what I hear from the COVID MS people all the time. So the thing is, this coming Saturday morning, or not Saturday morning, lunchtime, noontime, Eastern time, what we're doing is a telehealth call. I am playing an MS patient. Why? Because I am an MS patient. Dr. Boster is playing an MS neurologist because he is an MS neurologist. And we're going to have a real telehealth call. And I've got a list of symptoms to talk about with him. So we are going to do this, and we are not rehearsed in doing this. And we're doing this so that way we could show all of you and everybody else that comes online what it is to do this call correctly. So that way when you sit with your doctor online, that you can come out with a certain way of doing it and making it a very useful experience. Okay. All right.
I love that. I think that's such a great idea.
Thank you. And then on Sunday, we have a hybrid program going out of here in Central Florida with Patricia Pagnotta. That's right, Megan. We're doing a hybrid program out of Central Florida. In fact,
hybrid.
We'll be in, well, we have people coming. We have people coming. We're going to have a 5,000 square, we have a 5,000 square foot ballroom. We're putting just 30 people inside. Now, normally for 5,000 square feet, we could get 170 people in the room. All right. We're only putting 30 people in the room, 4 people per table. The tables will be 20 feet apart, staggered, so everybody is far away from each other. Masks are required to be worn during the program. And why is it hybrid? Because we're also doing it virtually. Okay, so that's the new hybrid, is doing something live and virtually at the same time. Okay.
So I just found a little bit about the IVIG. It looks like it looks like they should be given at least 2 weeks before an IVIG infusion.
Can you give me shorts?
Not right now, buddy. I can soon.
No, not soon. Not soon.
They can go.
I don't want you in front of the camera. Thank you. Thank you.
I want.
That's what I found, but that's related to live vaccines.
Okay. Thank you for that. And, you know, we're going to end it now because I know you're a little stressed. All right. Elizabeth wants you to know how wonderful Megan is. And she also writes, Stuart, you're great and good way to control the situation. Okay. Thank you, Elizabeth.
Elizabeth, hey, thank you. I know who that was.
I want to thank you. I want to thank everybody for being on here. I want to thank you all for your patience with little Dane in the background there. And Megan, I thank you for not losing your cool and yelling at your son. All right. And we're going to have a great time tonight, right? All right. Go take care of Dane. And people are writing, great job. Good work.
Thank you, guys.
Thanks for the program. Keeping it all going. And one person wrote, Dane's cool. Okay. So, yeah, we got it going. All right. Thank you again, Megan. And we are going to see you again soon. Everybody should know we're going to put Megan in another building the next time we do this.
I will stay in my office. This is try.
Either that or we're going to have you come to Longwood again, all right?
Yeah.
You can sit in front of this nice, pretty wall, all right?
Yeah.
Okay, great. All right, awesome. Everybody, thank you for being online with us tonight. And again, this is an MS Views and News program. It's called MS Views Now, and it will be on our YouTube channel by this coming Saturday afternoon. I want to say thank you for everybody for being here. Thank you, Megan. Namaste. Have a great night.
Good night.
Good night.